it's important to read through these because this is what primarily exams are going to be focused on. Acid-base imbalance, like we've talked about previously, the body is always trying to maintain a normal balance of homeostasis. This includes your acids and bases as well as your fluid and electrolytes. An acid-base imbalance is not a disease, though. It's a manifestation of an underlying problem. For example, if someone has pneumonia and is having poor oxygen exchange, they're going to be probably respiratory acidosis. So the acidosis isn't the disease, it's the pneumonia that's causing the acidosis. So keep that in mind. So when you have a lot of patients in for different things, that an acid-base imbalance can be a part of their disease process. So it isn't, and when you're identifying a specific acid-base imbalance, it's important because each one has a different treatment. You're going to be using this by analyzing arterial blood gases. This helps with the diagnosis, guides the treatment plan. When you have a patient with a ventilator or that's on a vent, or if you're trying to wean vents or do anything with oxygen, a lot of times you'll look at acid base or your ABGs or your VBGs to check on how they're progressing. Here's a quick breakdown on where to find your basically an arterial line in your radial arterial line. There is a femoral one and a brachial as well. Generally, the radial wrist one is the one where they'll get. Every facility has a different scope on who can draw these labs and who can access them. So make sure you're allowed to draw them before you're going to get those. Like I said, they can be used to assess several things like respiratory compromise, medical conditions such as sepsis, DKA, renal failure, toxic substance ingestion, drug overdoses. We go when it was earlier. You can evaluate the effectiveness of oxygen therapy, ventilator support. If your patient is on oxygen and you draw an ABG, you can tell to see if they're still maintaining. If you're weaning their oxygen, you can tell to see if their CO2 is elevating, so you know whether it's effective or not. Also, vent support, fluid electrolyte replacement, and during perioperative care. What is plasma pH? Plasma pH is an indicator of the hydrogen ion concentration, and it measures the acidity or alkalinity of the blood. Hydrogen concentration is extremely important. It's kind of an inverse proportion of what you think it's going to be. The higher the concentration, the lower the pH. So sometimes it takes a second to think about that. So if you have a lot of hydrogen, your pH is going down. If you have a little bit of hydrogen, your pH is going up. Okay, so like we just said, the concentration is usually expressed as a negative logarithm. So the higher the number of the hydrogens, the lower the pH. We just went over that. So normal metabolic process produces acid. The body needs to neutralize and excrete these to maintain your normal balance of acid and bases. The pH range is very, very narrow. Pretty much anything below 6.8 or above 7.8 can result in death. The pH itself, a normal human, is running between 7.35 and 7.45. Anything below or above it's going to be your acidosis or alkalosis. This is one of those areas where I've talked a lot in the past about. Usually when we give a range, a number, it's going to be, you can tell it's out of whack because we usually have like some sort of a disclaimer almost over every lab saying, lab results may vary, hospital ranges may vary, this or that. pH is one of those ones that's pretty standard, that your goal is to stay between 7.35 and 7.45. So there are some maintaining the balance. You've got your extracellular buffer system. Bicarbonate will buffer your acid in your lungs, controlled by the medulla, regulate your CO2 and those carbonic acid in the extracellular fluid, where your kidneys regulate bicarbonate in your extracellular fluid. When you're regulating your pH, there's several systems that actually help work it. Your buffers work immediately. They're the primary regulator acid base. Your respiratory system can take a couple minutes if you think about it. If you have high acid, if the popular one to go to is your DKA. with your telltale Kussmaul's respirations. What are they? They're rapid, deep breaths. So you're breathing really fast and really deep because you're trying to expel all that CO2. Well, that can work. It takes a couple minutes, but it starts working in minutes because you're blowing off that extra CO2. And after an hour, after hours, you can be most effective. But if you think about it, the respiratory system isn't a permanent fix. You can't breathe deep and fast forever. So it's something that is an emergency and needs to be treated. Your renal system, because your renal system, how does it take care of acids, excreting acids or bicarbs? Is through voiding. Well, it takes a lot of time to produce enough urine to actually compensate for these things. So it can take up to 2 to 3 days to respond maximally. Now, if it's a metabolic issue, or respiratory, if your kidneys are able to get to the point where your body can hit homeostasis, hit between that 7.35, 7.45, it can maintain that balance indefinitely because you're not having to breathe fast. Your kidneys can keep excreting. So buffers, like I said, act chemically to change strong acids to weaker ones, and it binds to acids to neutralize their effect. Cells can actually act as buffers as themselves by shifting hydrogen in and out of the cells. So if you are acidic, your cells themselves will actually absorb a hydrogen ion, and when they do that, they excrete a potassium cell. So you got to worry about if your patient is going into acidosis and have the increased hydrogen, you got to be watching for hyperkalemia as well. And then you have to worry about all the things that come with hyperkalemia, your EKG rhythm changes and those things. And on the reverse, with the decrease of hydrogen, so if you're going alkalotic, your cells will excrete a hydrogen ion and then absorb a potassium ion in its place. So, and then you can worry about going into hypokalemia because it's actually going to be, your cells are going to be holding on to the potassium instead. There's a carbonic and bicarbonate buffer system. So basically, CO2 with water will form carbonic acid. So with your bicarbs and these, through bringing back your old chemistry days, breaking down your chemicals this way, the strong acid with the strong base breaks it down to decrease your blood's pH, buffered into sodium and a weak acid. And your carbonic acid is then broken down into water and carbon dioxide. Like I said, lungs excrete the CO2, and either is combined with insensible water or is excreted as CO2. So as your lungs do this, it helps try to maintain the amount of CO2 needed to keep your acids where it needs to be. We're using your respiratory system to regulate it, your CO2 enters the red blood cells, combines with water, forms carbonic acid. The carbonic acid dissociates hydrogen ions and bicarbonate, and then free hydrogen is then buffered by hemoglobin, and bicarbonate diffuses in the plasma. In the pulmonary capillaries, this process is reversed and CO2 is formed and excreted by the lungs. So that's kind of the chemical version of what's happening. So if an increased amounts of CO2 or hydrogen ions are present, then you're going to increase your respiratory rates, and you're going to leading to increased CO2 elimination and decreased CO2 in the blood. Like we said, if you're going acidotic, the telltale is the Kussmaul's respiration. What are you doing? You're going fast and you're going deep, so you can pull out and breathe out as much CO2 as possible. If you got low, you're going to have decreased respirations. So you're going to breathe slower, trying to hold on to that CO2 to keep it in you a little longer to form that additional acid. Your renal system conserves bicarbonate and excretes acid. So that's how your metabolic side helps work it, right? So there's 3 mechanisms for acid elimination. One is it secretes free hydrogen in the renal tubule, or it can combine hydrogen with ammonia to form ammonium and then excrete weak acids. The kidneys normally excrete acid in urine. Normal average pH is 6. As a compensatory mechanism, the pH of urine can decrease to 4 or increase to 8. So as it's retaining or excreting acid, it can vary as well. So to compensate for acidosis, the kidneys can reabsorb additional bicarb and eliminate excess hydrogen, increasing the blood pH, decreasing the urine pH. Other buffer systems in the extracellular fluid, you have inorganic phosphates, and in intracellular, you have proteins, organic and inorganic phosphates, and your hemoglobin. So keeping a balance results, the imbalance results in there's an alteration in the ratio of 20-1 between base and acid. Remember, it takes roughly 20 units of bicarb to counteract 1 unit of hydrogen. So if your body, basically when those fail is when you start going into a acidotic or alkalotic direction. Your imbalances can be classified by depending on the primary cause. So you have basically 2 forms. You have a metabolic system, or you have a respiratory system. Respiratory, through this we'll talk about you form whether it's too much CO2 or too little CO2 or too much bicarb or too little bicarb, and that'll direct you to whether it's an acidosis or an alkalosis. And then acute or chronic is something like, for example, a patient with COPD they're going to be in a chronic state of a respiratory acidosis portion because they retain more of their CO2. So like I said, just an alkalosis, blood has too much base, too little acid, resulting in an increase in pH. So a decrease in carbonic acid or an increase in bicarbonate. Acidosis is the blood has too much acid, resulting in a decrease in pH, and this is where you have an excess of carbonic acid or a decrease in bicarbonate. Okay, remember this number is good to know. Keep it several times, 7.35 to 7.45. Those are the numbers you really want to make sure you're remembering as well. Here's just another way to remember: alkalosis, your pH is going up; acidosis, your pH is going down. Just another way to remember it. Okay, metabolic imbalances are caused by an imbalance in the production of acids or bases and excretion of the kidneys, where respiratory imbalances are caused by changes in carbon dioxide exhalation due to lung disorders or affecting breathing. ABGs, these are the values you're going to want to make sure you know. 7.35 to 7.45 for your pH. 7.4 is your happy medium, so you want to make sure you're knowing these. Your CO2, 35 to 45. And then your bicarb is 22 to 26, with 24 being the middle. Assuming average values for ABG interpretation. Okay, your PaO2 is 80 to 100. Oxygen saturation is greater than 94%. So you just need to make sure you're familiar with these numbers when going through and calculating your ABGs or interpreting them. Okay, we're going to talk about metabolic acidosis now. Metabolic acidosis is a low pH, so that's below 7.35. Low bicarbonate, below 22. Remember, because if you have less bicarbonate, you're going to have more hydrogen, which is going to make your pH lower. Most commonly due to kidney injury. Remember, because your kidneys are where the excretion is happening, so that's where you're going to see that. Some common manifestations: headache, confusion, drowsiness, increased respiratory rate and death, decreased blood pressure, dysrhythmia, shock, because dysrhythmia is we talked about, because if you're in acidosis, what's your body doing with the cell at the cellular level? They're kicking out more potassium. And if decrease is slow, patient may be asymptomatic until bicarbonate is 50 milliequivalents or less. A lot of times, correct the underlying problem will correct the imbalance. And that could be by giving bicarbonate, PO or IV. Metabolic acidosis also can excessive acid, or you got a base bicarbonate deficit caused by ketoacidosis, lactic acid accumulation, diarrhea, or kidney disease. So we talked about these here. Ketoacidosis, you got your lungs. Your body's basically producing so much ketones, which are acidic, which is going to raise your metabolic side of your acidosis. your lungs are going to breathe faster. Remember, in your diabetes lecture, what are you expecting to see? Kussmaul's respirations, which are deep and rapid, and your kidneys are going to try to attempt to excrete additional acid. With acidosis, hyperkalemia may occur, like we talked about that, as potassium shifts out of the cell. And as it's corrected, potassium shifts back into the cell, and the potassium levels decrease. So it's important to monitor your potassium levels as you're going through the patient's treatments of acidosis. So serum calcium levels may be low with chronic metabolic acidosis and must be corrected before treating acidosis to avoid tetany resulting from increased pH and decreased ionized calcium. Anion gap. This is an interesting concept. To be honest, I didn't really know much about it until I was working in the hospital in the ICU, and we had patients coming in DKA, and they'd be on a 2-bag drip system and in the ICU status and on insulin drips until their ion gap closed. And so it was learning what the ion gap was and learning how it closes, and that's when they know it's whether the patient is safe to transition back to regular insulin versus the drips. So it's good to know what it is and how it works and what it means. A normal ion gap is between 8 and 12. Potassium can be added or removed from the equation, which we'll talk about shortly. But we're going to 8 and 12 without potassium. So if it's increased, that means you have a gain in acid. So it's going to be lactic acidosis, diabetic ketoacidosis, etc. Like I said, when we have patients coming in DKA, we have to wait for the ion gap to close before we can take them off of the insulin drips and convert them to regular Lantus and Humalog. Normal metabolic acidosis is caused by carbonate loss, for example, diarrhea or use of diuretics. So going through this here, calculation example, your ion gap is your sodium minus your chloride and your bicarb. If you have potassium in there, it would be sodium plus potassium, but then the ranges change a little bit from 8 to 12 to a little different, so it's easier just to remember this formula here. So I said, so sodium minus chloride plus your bicarb, so 134 minus 108 plus 16 would equal 10. Right, and because the gap is 8 and 12, it is normal. Remember the slide from the previous lecture? I like it because it kind of shows what we're talking about here. So you have your sodium, and then you have your chloride plus your bicarb. So you subtract those together. That gap between the two of them is your ion gap. And as you increase in proteins through DKA and those things, your protein gets larger, increasing your gap. And as you excrete your proteins, stuff like those as well, helps remove those, then now putting your ion gap closed. Going through metabolic acidosis still. Now you've got a high pH, most highly bicarbonate, alkalosis. So it's a pH above 7.45. And you're with high bicarbonate above 26. So if you have a lot of bicarbonate, you are now basically being able to counteract more of the acid. So your pH is going to go up. Most commonly due to vomiting or gastric suctioning. If you have a patient on low intermittent suction, they're pulling all the contents out of the stomach. That's where a lot of your acids are produced. So you're going to be losing a lot of. So if you have a lot of vomiting and stuff like that, you're going to be losing. A lot of acid at that point. So you're going to be alkalotic by that sense. It may also be due to medications, especially long-term diuretic use. Hypokalemia will produce alkalosis. Remember we talked about if you have low potassium, your body's going to absorb a hydrogen ion and then to kick out a potassium. So that would be part of that as well. So symptoms related to decreased calcium, respiratory depression, tachycardia, and symptoms of hypokalemia. And if you think about with PO2, if you take base bicarbonate excess, if someone's crunching on Tums, 15 a day or something like that, you're gonna lead to alkalosis as well, like your prolonged vomiting, gastric, or gain of bicarb, ingestion of baking soda. So people Some people, you see them walking around eating Tums like candies all day. So those are some people you could be concerned about. So some ways your body compensates for it is you're going to have renal excretion of your bicarb, and it's going to you're going to be looking at a decreased respiratory rate to increase your plasma CO2. Now you can only do so much with that, but that's what your body will generally try to do to compensate for some of that. You always have to correct the underlying disorder, supply chloride to allow excretion of excess bicarbonate, and restored fluid volume with sodium chloride bolus solutions. So with respiratory acidosis, that's when your pH, remember it's acidosis, so your pH is going to be low at 7.35 or below. Your CO2 is going to be higher than 42. So always, respiratory issues always due to respiratory problems with inadequate excretion of CO2. Either hypoventilation, respiratory failure, chronic respiratory acidosis may be constipated, body may compensate, but it may be asymptomatic. So like I say, your kidneys are going to conserve bicarb and secrete hydrogen in urine. So when you have respiratory acidosis, your symptoms may include increased pulse, increased respiratory rate, trying to blow off CO2, mental changes, feeling of fullness in the head. You're looking at with acidosis, respiratory acidosis, you get a potential risk of intracranial pressure. If the CO2 increases rapidly, you've got cerebral vasodilation will increase intracranial pressure, and cyanosis and tachypnea will develop. So treatment will be, and your main treatment is, because if you're not doing that CO2 exchange, is going to be aimed at improving ventilation to improve that ventilation. With alkalosis, you're looking at a high pH above 7.45. Pretty much always due to hyperventilation. So if you're blowing off a lot of CO2, your pH is gonna go up. Lightheadedness, inability to concentrate, numbness and tingling, possible loss of consciousness. What you have to do is correct the cause of hyperventilation. So some of these things could be extreme anxiety. What happens when people, when they're stressing out, they can't breathe so fast. Remember, they used to have, what would you used to have them do? Breathe into a bag or something like that. You always see when people are stressing out, or slow down. when people are stressed out, you have them slow down, take some deep breaths, right? Because you're trying to slow down what they're doing. Also, things to think about: alkalosis. If their vent settings are wrong, you could possibly be having them breathe too fast, and that could be causing respiratory alkalosis too, because you're breathing too much. Or the tidal volume. If you have your volumes too much, you could be removing too much air at the same time. Respiratory alkalosis, rarely accused or acute, can buffer with bicarbonate shift, renal compensation if chronic. So, like I said, a lot of respiratory stuff can be, it's hard to compensate for respiratory issues because respiratory is so important with oxygen and stuff like that. So you don't have a lot of time to really buffer a lot of that. And that sums up the respiratory acid and bases. There will be one more lecture that's coming up that'll be how to actually interpret their ABGs. So look forward to talking to you then. Once again, here's my email address.